Medical Director of Eastern Railway. He is also presently the President of Railway Forum of Indian Society of Anaesthesiology, and Dr. Reshmi Verma, who is presently working as Additional Chief Medical Superintendent in Western Railways. She did her MD Anesthesiology from SMS Medical College, Jaipur, and has done Diploma in Hospital Administration from New Delhi and certificate course in telemedicine from All India Institute of Medical Sciences, New Delhi. A few words about the auspicious Dr. A.M. Roy Memorial Oration. Dr. Amulendu Mohan Ray graduated from Calcutta Medical College in 1939 with a gold medal. He joined Bengal Medical Services in 1940 at Campbell Medical School, presently NRS Medical College, as anesthesiologist. He joined Bengal Assam Railways in 1942 in Guwahati, worked at B.R. Singh Hospital, Eastern Railway. He was next transferred to Bengal Nagpur Railways and Southeastern Railway and worked in all the divisions and headquarters. He was a part of the team in planning and construction of the Central Hospital at Garden Reach. He retired from Railway Board in 1972. This oration was instituted in RFSIA by his son, Dr. Aurobindo Ray, who is presently the Medical Director and Chief Anesthesiologist, Central Hospital, Southeastern Railway, Garden Reach.
Today, the Dr. A.M. Ray Memorial I'll just read out the biodata of Dr. Reena Ramphil. She joined Indian Railways in 1982 and worked in Western Railway at different places. At present, she is working as Additional Chief Health Director and HOD of the Department of Anesthesiology and Advanced Pain Management in Jagjivan Ram Hospital, Mumbai. She has a great interest in the field of acute and chronic pain management. Has also been working as Honorary Secretary of the Railway Forum of ISA since last year. I invite Dr. Reena to please present the oration. Before that, as is the tradition, the medallion has to be presented to Dr. Reena. I'll request Dr. Rashmi to please present a medallion to Dr. Reena before she starts the oration.
My seniors and colleagues. Today I am going to present COPD and anesthesia. The Global Initiative for Chronic Obstructive Lung Disease Guidelines defines COPD as a disease state characterized by airflow limitation that is not fully reversible, usually progressive and associated with an abnormal inflammatory response of lungs to inhaled noxious particles and gases. COPD has two components: chronic bronchitis, where inflammation of small airways occur, and emphysema, where parenchymal destruction occurs. Pathophysiologic changes in COPD occur in large airways, small bronchioles, and lung parenchyma. Most cases of COPD are the result of exposure to noxious stimuli, most often cigarette smoke. The normal inflammatory response is amplified in persons who are prone to develop COPD. Increased numbers of activated polymorphonuclear leukocytes, macrophages, releases elastase in a manner that cannot be counteracted effectively by antiprotease, resulting in lung destruction. Now, primary offender has been found to be human leukocyte elastase. With the synergistic role of all these factors and oxidative stress caused by cigarette smoke, increasing age and autoimmune mechanisms also play a role in pathogenesis of COPD. Now, histologic hallmark of chronic bronchitis is mucous gland hyperplasia along with smooth muscle hypertrophy, global cell hyperplasia, inflammatory infiltrate, excessive mucus and squamous metaplasia. Along with all these changes combined with loss of supporting alveolar tissue causes airflow limitation. Now, chronic bronchitis is associated with relatively undamaged pulmonary capillary bed. The body responds by decreasing ventilation and increasing cardiac output, leading to hypoxemia and polycythemia. Eventually, hypercapnia and respiratory acidosis develops, leading to pulmonary artery vasoconstriction, cor pulmonale and right heart failure, and they are also known as blue blotters. Emphysema is defined by permanent enlargement of air spaces distal to the terminal bronchioles, leading to dramatic decline in the alveolar surface area available for gas exchange. Loss of alveoli leads to airflow limitation by two mechanisms. First is loss of alveolar walls, results in decrease in elastic recoil, and second is loss of alveolar supporting structures, leading to airway narrowing. The gradual destruction of alveolar septa in pulmonary capillary bed in emphysema leads to decreased ability to oxygenate blood, and the body compensates with lower cardiac output and hyperventilation. Now, because of low cardiac output, the rest of the body suffers from tissue hypoxemia and pulmonary cachexia. Eventually, patient develops muscle wasting and weight loss, and they are also known as pink puffers. Now, this is the physical look of patient in emphysema and chronic bronchitis. Now, cigarette smoking is the primary cause of COPD. Overall, tobacco smoking accounts for as much as 90% of COPD risk. Other etiology factors are environmental pollutions, airway hyperresponsiveness, and deficiency of alpha-1 antitrypsin protein. The National Health Interview Survey reports the prevalence of emphysema at 18 cases per 1,000 persons and chronic bronchitis at 34 cases per 1,000 persons. Although current rates in COPD in men are higher than women, the rates in women have been increasing. COPD occurs predominantly in individuals older than 40 years. Now, as far as prognosis is concerned, COPD was 6th cause of global mortality in 1990, but now it is at 4th position, and it is predicted that it will be on 3rd position in 2020. The FEV1 was used to predict outcome in COPD, but now other factors are also identified in determining the outcome of the COPD patients, and they are body mass index, obstruction, dyspnea, and exercise capacity. They have created multidimensional board index. When we take history, patients typically present with combination of signs and symptoms of chronic bronchitis, emphysema, and reactive airway disease. Symptoms are productive cough, acute chest illness, breathlessness, wheezing, and systemic manifestations are decreased fat-free mass, impaired systemic muscle function, osteoporosis, anemia, depression, pulmonary hypertension, cor pulmonale, and left-sided heart failure. There are certain characteristics which differentiates predominantly between if they are chronic bronchitis or emphysema case. In chronic bronchitis, we get patients with obese patient, frequent cough, expectorations are typical, use of accessory muscles of respirations are common, and coarse rhonchi with wheezing may be heard on auscultation. Patient may have signs of right heart failure such as edema and cyanosis. In emphysema, patient may be very thin with barrel chest, typically have little or no cough. Breathing may be assisted with pursed lip, use of accessory muscles are there, and patient may adopt the tripod sitting position. The chest may be hyperresonant and wheezing may be heard. Heart sounds are very distant. In investigation, arterial blood gas analysis provides best clues to acuteness and severity of disease. When it is mild COPD, there may be mild to moderate hypoxemia without hypercapnia, but as the disease progresses, hypoxemia worsens, hypercapnia may develop, FEV1 falls below 1 liter per second or 30% of the predicted value. In general, renal compensation occurs even in chronic CO2 retainers, thus pH is usually found near normal. That's why any pH below 7.3 to be considered as a sign of acute respiratory compromise. In person with stable chronic bronchitis, the sputum is mucoid and macrophages are prominent cells. But with the exacerbation, sputum becomes purulent and with the presence of neutrophils. When we see X-ray chest, chronic bronchitis is advocated it is associated with increased bronchovascular markings and cardiomegaly. With complicating pulmonary hypertension, the hilar vascular shadows are prominent and possible right ventricular enlargement and opacity in lower retrosternal space. In case of emphysema, X-ray chest reveals signs of hyperinflation, including flattening of the diaphragm, increased retrosternal air spaces, and long narrow heart shadow. Rapidly tapering vascular shadows accompanied by hyperlucency of lungs are the other signs of emphysema. High resolution CT scanning is more sensitive and specific than standard chest radiography. For diagnosis of emphysema, here in this CT scan, this outline bullae, they are not always visible in X-ray chest. In ECG, we found right ventricular hypertrophy and there may be right atrial enlargement. And 2D echo, it will confirm the right-sided heart failure in long-standing COPD cases. Pulmonary function tests, they are essential for diagnosis and assessment of severity of disease and they are helpful to monitor its progress. FEV1 is a reproducible test and most commonly used index of airflow obstruction. Now, dynamic hyperinflation during exercise is thought to be a greater contributor to the sensation of dyspnea than airflow obstruction alone. Now, this is the flow volume curve of the patient. This is of a emphysema patient, shows marked decrease in expiratory flow and hyperinflation due to air trapping in comparison with this patient A with a restrictive lung disease who has reduced volume and preserved flow. There are few bedside pulmonary function tests, that is Snyder's match doing test. This test is always for the patient maximum breathing capacity and it is there is an ability to blow the matchstick of 22 centimeters from mouth indicates the maximum breathing capacity of 150 liter per minute. If it is a 15 centimeter distance, then mouth breathing capacity is more than 100 liter per minute, and if it is 7.5 centimeter distance, maximum breathing capacity is found more than 50 liter per minute. Breath holding test, that is patient is asked to hold his breath after taking deep breath, and breath holding time, if it is more than 40 seconds, it is normal. Between 20 to 30 second breath holding time indicates compromised cardiopulmonary reserve and less than 20 seconds indicates poor cardiopulmonary reserve. Peak expiratory flow rate, it is advocated in case of asthma, and forced expiratory time, if it is more than 6 seconds, indicates severe expiratory airflow obstruction with FEV1 less than 50%. Alpha-1 antitrypsin deficiency screening is also done when we found COPD at younger age and if there is a strong family history. Now, severity of COPD is classified as per the gold star criteria. When FEV1 is around 80% predicted, then it is mild obstruction. If it is between 50 to 80% predicted, it is considered as a moderate obstruction. If it is 30 to 50% predicted, it is severe obstruction, and FEV1 is less than 30% predicted or less than 50% along with chronic respiratory failure, then it is very severe obstruction. Now, the goal of COPD management is to improve patient's functional status and quality of life by preserving optimal lung function, improving symptoms, and preventing the recurrence of exacerbations. There are some recommendations provided by board for management of COPD. In stage 1, reduction of risk factors by giving influenza vaccine, short-acting bronchodilators when needed. In stage 2, treatment of stage 1 along with long-acting bronchodilators and cardiopulmonary rehabilitation. In stage 3, treatment of stage 2 along with inhaled corticosteroid if there is a repeated exacerbation, and in stage 4, treatment of stage 3 plus long-term oxygen therapy and surgical options may be considered. Now, in anesthesia management, pre-operative management, when we take history, if there is recent changes in dyspnea, sputum and wheezing, FEV1 less than 20%, 25%, and dyspnea with minimal activity, or FEV1 less than 50% with dyspnea on exertion, then always review of investigations to be done, especially of ABG, chest X-ray, sputum examination and clinical examination. Careful cardiac evaluation is always advocated for core pulmonary and pulmonary hypertension, and the goal is to optimize patient. To optimize patient, advise to stop smoking, treat infection with antibiotics, drug therapy of COPD to be continued in perioperative period, breathing exercise like deep breathing, incentive spirometry is advocated, mucolytic therapy and adequate hydration of patient for loosening of secretion is also advised. Now, why to quit smoking before surgery? Here, cessation of smoking of 4 to 6 hours, there will be decrease in nicotine level. At 12 hours, carboxyhemoglobin level decreases. At 4 to 6 days, ciliary activity recovers. At 1 to 2 weeks, airway hyperreactivity decreases. At 2 to 6 weeks, sputum volume decreases. At 3 months, tracheobronchial clearance occurs, and at 6 months, immune function improves. Now, preoperatively, drug therapy to be continued. They may be inhaled bronchodilators like beta-2 agonist, anticholinergics, inhaled corticosteroids, oral steroids, and theophylline, but theophylline has a low therapeutic index. In case of pulmonary hypertension and right ventricular dysfunction, diuretics, oxygen therapy, and dejection may be advised. Phosphodiesterase inhibitors like sildenafil is also used, but it causes exaggerated hypotension and the gastroesophageal reflux intraoperatively. Tiotropium is a new quaternary ammonium compound that also causes bronchodilator, and infusion of alpha-1 antitrypsin helps in slowdown of lung damage. Breathing exercise like deep breathing exercise, incentive spirometry and chest physiotherapy is advocated pre-operatively. Now, plan of anesthesia. There are some advantages and disadvantages of general and regional anesthesia. In general anesthesia, advantages are it gives control ventilation, better relaxation, and patient is more comfortable. But airway reactivity, dynamic hyperinflation, and post-operative effect of anesthetic agents are the disadvantages. Regional anesthesia avoids airway handling, minimize need for sedatives, but handling is uncomfortable and intercostal blockade may impair respiration. There are many advantages of epidural analgesia if it is included with general anesthesia, and they are early ambulation, good analgesia, early nebulization, decreases DVT, aggressive chest physiotherapy can be done, and it reduces post-operative pulmonary complications. Pre-operatively, anxiolytic may be considered in absence of hypercapnia. Bronchodilator to be continued. Consider changing inhalers to nebulizer. Atropine decreases airway resistance, airway reactivity, bronchospasm, but it can cause mucus plugging. And opioids are always avoided. For induction, thiopentin causes bronchospasm in lighter plane. Propofol causes propofol is a bronchodilator, but it causes hypotension, and ketamine is also bronchodilator, but it causes tachycardia and hypertension. So base agent is propofol. Now for reduction, CPAP and BiPAP may be attempted prior to intubation in case of extreme cases, and sevoflurane is best for rapid inhalation induction. In case of obstruction, rapid sequence intubation is preferred, and to secure airway, cuffed endotracheal tube is used. LME is not suitable for upper abdominal surgery because of high risk of respiration and high airway pressure. In monitoring, ECG, SpO2, and tidal carbon dioxide monitoring, temperature, hourly urine output, peripheral nerve stimulator, blood pressure monitoring. Especially with, it is preferred with arterial cannula because it gives frequent sampling and frequent blood pressure monitoring. Pulmonary wave pressure monitoring is more preferred than CVP monitoring in case of pulmonary hypertension. Maintenance is always with halothane. Nitrous oxide is contraindicated in case of pulmonary hypertension or emphysematous bullae. Epidural infusion is for intraoperative and postoperative analgesia, and intraoperatively IV fluid boluses is preferred instead of continuous large volume. Now there are few intraoperative problems. First is increasing airway pressure, and it is due to bronchospasm, endobronchial intubation, mechanical kinking of circuit, light flame. Surgical causes are like position retraction and packing, pneumothorax and hyperinflation. Second is persistent hypotension intraoperatively, and it is because of epidural effect, anesthetic effect, hypovolemia due to blood loss or fluid shift, pneumothorax, left ventricular dysfunction, and dynamic hypertension. In dynamic hypertension, here volume is trapped in the lung and it causes autopip and it causes hypotension. And how to confirm diagnosis of dynamic hyperventilation? First, disconnect ventilator, allow 30 seconds of apnea so that venous return increases. Blood pressure should normalize, and this test is called apnea test. Another complication intraoperatively is the bronchospasm, and it can be treated with increased FiO2, deepening of anesthesia. It relieves mechanical stimulation, sucking out ET tube, beta-2 agonist, subcutaneous terbutaline, IV adrenaline and corticosteroids, and aminophylline. Now, ventilation strategy. Ventilation strategy should allow adequate expiratory time, and for that decrease IE ratio, decrease respiratory rate, and increase inspiratory flows. To reverse patient and extubation, patient should be awake, warm and comfortable. There should be no intraoperative problems. Neostigmine also causes bronchospasm, and if post-operative ventilation to be continued, then same ventilation strategy should be adopted. In post-operative management, adequate pain control, control oxygen therapy which should be humidified, breathing exercise, ambulation, DVT prophylaxis and selective nasogastric decompression is advocated. Now, which patients are at high risk for the post-operative pulmonary complications? There are few predicting factors like patient factors and surgical factors. In patient factors, age more than 70 years, ASA grading 2 or more, COPD, smoker, functionally dependent and low albumin are the factors. And in surgical cases, surgical factors are site of surgery like upper abdominal, thoracic and aortic surgery, emergency surgery, prolonged surgery more than 2 hours, and general anesthesia. Now, take home message is always optimize patient prior to surgery, as COPD is no more a specialist concern, it is ours. It is alarmingly increasing but preventable. For the vast majority of patients, cessation of smoking is the only true means of prevention. Always use spirometry and peak flow meter just as ECG. Don't embark on dariphyllene and steroids for all breathlessness. Don't use theophylline as far as possible. Inhalation therapy is the best for drug delivery. Don't spare anybody from early oxygen therapy. And finally, motivate smokers to quit smoking. These are the references from where I have made this presentation. Thank you.
Thank you, Dr. Rina. As no questions are permitted in oration, So that's it. Thank you very much.
Thank you, madam. Now I request Dr. S.S. Rathur, CMD Eastern Railway, to present a memento to Dr. Parampil. Thank you. Now I request Dr. P.S. Prasad, CMD East Central Railway, to present a memento to our chairpersons. First to Dr. Rathod. First to Madam Mrs. Burma. Next to Dr. Rathod. Thank you, sir.
The next session is Dr. B.N. Ghosh Memorial Oration. The speaker is Dr. Shumanta Dashgupta, and he is going to speak on safe practice of anesthesia. This session is going to be chaired by Dr. A. Prakash, who is presently the Senior Professor in Railway Staff College, Vadodara. He has done his MD in anesthesia and MBA from XLRI Jamshedpur, and Dr. Bree Mishra, who is the ex-CMS Division Hospital, Kharagpur. He is presently working as Principal Medical Officer, BC, Roy Technological Hospital, IIT Kharagpur. A few words about B.N. Ghosh Memorial Oration. This oration was introduced in 2002. Dr. B.N. Ghosh was the first qualified anesthesiologist in Indian Railways Medical Services. He worked at B.R. Singh Hospital and Howrah Orthopedic Hospital, Eastern Railway. Late Dr. A.R. Das, anesthesiologist of Eastern Railway, donated the money in the memory of his friend.
Dr. Shumanta Dashgupta needs no introduction to the House. However, one of our most promising anesthesiologists of Indian Railways. He did his DIP card from IPGMR Kolkata, MD from PGI Chandigarh, joined IRMS 26 years ago, worked at Mumbai, Bhusawal, Agra, apart from here at your own hospital, this hospital. He was past secretary of Indian Society of Anesthesiology West Bengal branch, organizing secretary of annual conference of National RFSIA in 2008 in Kolkata. He is organizing secretary of annual conference of ISA East Zone 2010 arranged in Oberoi Grand, and he is a Rotarian. So we will wait anxiously to listen his oration. Thank you.
Thank you, chairpersons, for your kind words. This particular oration is a very prestigious oration, and this has been introduced in 2002, and it was named after, as already been stated by the anchor persons from the podium. So I will not go into the details. The topic of today's discussion is safe practice of anesthesia, because anesthesia is such a subject where safety is always the prime issue, and safety we have to maintain in every step in day-to-day practice of our life. Quality assurance cycle, we all know, it consists of 4 basic things: monitoring of the existing practice, whatever we are doing every day, seeking improvement by feedback and other changes, then review of the results, and then standard setting. And this is a cycle which goes on and which basically propels us to think further what we are doing now and what better we could have done possibly in future. This is the present day OT suit of any international standard, or maybe in few of our national hospitals also. But we are lacking sometimes in these aspects, and all these facets of operating a suit or operating team is an important factor in providing safety to the safe practice of anesthesia. The operating team, as we all know, includes the surgeon, the anesthesia professionals, the nurses, the technicians, and last but not the least, the other operating room personnel involved in surgery, like the OT staff, the dresser, the ward boys, etc. Safety is a fundamental principle of patient care and a critical component of quality management, as I have already said. Its improvement demands infection control, safe use of medicines, equipment safety, safe clinical practice, and safe environment of care. It embraces nearly all healthcare disciplines and workers. An estimated 234 million major operations are performed around the world every year. So that's a huge figure, and corresponding to one operation for every 25 people alive. In industrialized countries, studies suggest that the major complications are reported to occur in about 3 to 16% of cases, and permanent disability or death ranges between 0.4 to 0.8%. Though in developing countries like us, the death rate is possibly between 5 to 10%. These standards, these international standards for safe practice of anesthesia, these standards are recommended for anesthesia professionals throughout the world. They are intended to provide guidance and assistance to anesthesia professionals. They are professional societies. This is very important, as we are talking of this now being under the umbrella of Railway Forum of Indian Society of Anesthesiologists. Hospital, the place where we practice every day, and facility administrators and government for improving and maintaining the quality and safety of anesthesia care. These standards were adopted by World Federation of Societies of Anesthesiologists, WFSA, on 13th June 1992, which were later revised and ratified on 5th March 2008 and 19th March 2010. The most important standards relate to individual anesthesia professionals. We must always remember that. The monitoring devices which play an important part in safe anesthesia, they can only be regarded as extensions of human senses and clinical skills rather than their replacements. This always should be kept in mind. The standardized language of WHO and WFSA, because these nomenclatures will be utilized in the rest of my presentation, they are highly recommended, and recommended, highly recommended plus suggested. So for the level 1 or basic requirement, we have the highly recommended guidelines. For the level 2 or intermediate group of recommendations, we have the highly recommended guidelines plus recommended guidelines. And for the highest level, the level 3 or the optimal level, you have the highly recommended plus few suggested guidelines. The professional status of these guidelines, now we started, what these international standards, what they have to say, which were coined in 2010. The WFSA views anesthesia as a medical practice. The professional organizations, appropriate organizations at local, regional and national levels for the setting of standards of practice, supervision of training and continuing education and professional development with appropriate certification and accreditation and general promotion of anesthesia as an independent professional specialty. Training, certification and accreditation, formal certification of training and accreditation to practice is recommended. It is not highly recommended, but it is recommended. Now, records and statistics. A record of the details of each anesthetic should be made and preserved with the patient's medical record. This is highly recommended. Peer review and incident reporting. An anonymous incident reporting system with case analysis and resulting suggested remedies is recommended. And about the workload, a sufficient number of trained anesthesia professionals should be available so that individuals may practice to a high standard without undue fatigue or physical demands. This is also very important because many of us, in fact most of us, are practicing anesthesia without this thing and most of the time not being available with this particular criteria. Personnel and anesthesia professionals should be dedicated to each patient and be immediately present throughout each anesthetic and should be responsible for the transport of the patient to the post-anesthesia recovery facility and the transfer of care to appropriately trained personnel. Just not you hand it over to a post-op nurse without saying properly and without delivering the patient to that particular professional. It is not done. Facilities, equipment and medications. Appropriate equipments and facilities adequate both in quality and quantity should be present wherever anesthesia and recovery from it is undertaken. In service training and verification of an individual's ability to use a specific piece of equipment correctly and safely is required. So in a nutshell, appropriate anesthetic, resuscitative and adjuvant medications are required at each level. So that is very important to remember. Now, WHO in 2009 had come out with a safe surgery checklist. We all know that safe surgery saves lives and all. And there were evidence-based vital checks in 3 phases: before starting anesthesia, before starting surgery, and at the end of surgery. This checklist is intended to give teams a simple and efficient set of priority checks for improving effective teamwork and communication and to encourage active consideration of the safety of patients in every operation performed. The checklist has 2 basic purposes. It ensures consistency in patient safety and it introduces or maintains a culture that values achieving it. This is the famous surgical safety checklist which we are all aware of. The sign in, time out and sign out. These are the 3 phases where various things are to be ticked. This is a form which is available and you need to tick them so that this checklist is, once it is performed, you know that the basic steps in safety or safe practice of anesthesia has been undertaken. Peri-anesthetic care and monitoring standards. The first and most important component is the continuous presence of a vigilant anesthesia professional during anesthesia. This is very important, we all know that. Pre-anesthesia care is the evaluation, the anesthetic plan, all necessary equipment, whether they are available and functional, assistance if required should be available, and pre-anesthesia checks of the anesthesia system and facilities and equipment and supplies. Similarly, in the pre-anesthetic care, we need to see the pre-anesthesia checklist. Most of us are utilizing some of the pre-anesthesia form. We are all doing our pre-anesthesia clinic, check-up clinic, PSC clinics, and there various kinds of forms are available. People have adopted to their necessity. We have our own system of doing it also. And there you assess everything, the details of the patient, the history, the clinical examination, and of course the airway examination. Now, monitoring during anesthesia. After the pre-anesthesia period comes the monitoring during anesthesia. Oxygenation is one important aspect. Supplemental oxygen should be available and integrity of the supply checked. Adequate illumination and exposure of the patient should be made. Continuous use of pulse oximetry should be mandatory. Airway and ventilation, adequacy of airway ventilation to be continuously monitored, observed and auscultated if necessary. Breathing circuit, the reservoir bag to be observed. The respiration of the patient is transmitted to the reservoir bag. Disconnection alarm must be available in the ventilator. If anesthesia ventilators are being used, disconnection alarm must be there. In the circulation, the continuous display of the heart rate with pulse oximeter, continuous palpation of the pulse or auscultation of the heart is also required. Adequacy of tissue perfusion by continuous clinical examination and blood pressure measurements at regular intervals with non-invasive blood pressure. The temperature monitoring should be available where clinically indicated, particularly in prolonged or complex anesthetics or in young children. Neuromuscular function, the peripheral nerve stimulator is recommended. It is not highly recommended. Depth of anesthesia, regular assessment by clinical observation. BIS monitor is, even today, BIS monitor is neither recommended nor suggested. Audible signals and alarms and available audible signals and audible alarms are to be activated at all times. You should not make them mute just because you are getting disturbed. Should not make them mute because the alarms are there to alarm you. In the post-anesthesia care, facilities and personnel, all patients who have had an anesthetic affecting CNS function and or a loss of protective reflexes should remain where anesthetized until recovered or be transported safely to a specifically designated recovery location for post-anesthesia recovery. And monitoring in that particular area appropriate to the state of their CNS or PNS function, central or peripheral nervous system, vital signs and medical condition. Emphasis should be there on adequacy of oxygen, ventilation, circulation and temperature, pulse oximetry until consciousness has recovered. For pain relief, appropriate efforts to prevent and alleviate post-operative pain employing available appropriate medications and modalities. And what is our scenario? What we have just narrated, we have seen, we have heard, they are the international standards. But in most of our scenario, we are lagging far behind. And we possibly think and we assume that they are unattainable. No published minimum standards that deal specifically with resource-poor environments in which basic drugs and facilities remain a problem. And general hospital facilities do not form part of the WFSA standards but important enough to be considered, because in all these issues which have been discussed so far, electricity supply, running water, oxygen supply, etc. has not been mentioned. But they are equally, if not more important, while rendering safe anesthesia to our patients. I think our scenario is something like that when sophisticated workstations are already being in use. In many of the places, still we are using this boil F machine, which is very, very old. One study was done in 2008, it was published in Anaesthesia. Safety in anesthesia study of more than 12,000 reported incidents. It was done in UK by National Patient Safety Agency. 22.5% resulted in little or moderate harm and 2.1% resulted in severe harm or death. 8% incidents related to pre-op assessment with harm occurring in more than 26% of them, and 4.4% incident related to epidural anesthesia with harm reported in more than 35% of them. So this was a huge study. This was a huge study done by UK National Patient Safety Agency, and the data which was published afterwards told us a lot of things. This is of course the detail of the study. I am not going into the details, but there are various things which are important to notice here. That the delay, you can see here that the delay or difficulty in obtaining clinical assistance was also important. It was to the tune of, it could lead to severe harm or death to about 1.4%. Delay or failure to monitor could lead to 10.4% of the severe harm or death, and missing needle, swab, instrument or others, they could lead to 4.3% of the severe harm or death. So those things are very, very important, though trivial at times. but they actually constitute most of the complications which they had found in their study. Similarly, the allergy incidents and the unexpected events, you can see here, they are also quite important, and they had actually categorized all of them so that in future, for our the future generations, things could be prevented in a better manner. This preliminary analysis although is not authoritative enough to warrant widespread changes of practice, but it justifies future collaborative approaches to reduce potential for harm. Based on these particular study and the other recommendations by the international body, several guidelines, as I was telling, have been pointed out by various bodies, the European body, the American body, the UK body, and these in a nutshell are for the level 1, as I have said, the basic level, level 2 the intermediary level, and level 3 the highly recommended and suggested anesthesia standard. This is for the referral center. I think most of our hospitals feature in between in the level 2 category, and so we will concentrate what should be available in level 2. These are district or provincial hospitals within 100 to 300 beds. Short-term treatment of 95 to 99% of the major life-threatening conditions should be available. Essential procedures same as level 1 on these things, plus cesarean section, laparotomy, amputation, hernia, tubal ligation, closed fracture treatment, acute open orthopedic surgery, eye operations, removal of foreign bodies, and so on and so forth. And in personnel, one or more trained anesthesia professionals. I don't know whether we have achieved this. District medical officers, senior clinical officers, nurses, midwives. The drugs, all these drugs in level 1, ketamine, lidocaine, diazepam, pethidine, morphine. Many hospitals, morphine is still not available. Epinephrine, atropine, and apart from that, thiopental, succinylmethonium, pancuronium, neostigmine, ether, halothane, or other inhalational agents. Of course, nowadays we are having, many of the hospitals are having sevoflurane and desflurane. Lidocaine, bupivacaine, hydralazine, furosemide, dextrose, aminophylline, ephedrine, hydrocortisone, nitrous oxide. So these are the drugs which should be available in the level 2 category. For capital outlay equipment, complete anesthesia, resuscitation and ARV management system including reliable oxygen source, vaporizer, hoses and valves, bellows or bag to inflate lungs, face masks, work surface and storage, pediatric anesthesia system, oxygen supply failure alarm, adult and pediatric resuscitation sets, pulse oximeter, capnograph, defibrillator, ECG, laryngoscope, oxygen concentrator. So we know this list is exhaustive, but most of the things we have, but I think many of the things we also don't have, and we need to look at these charts and update ourselves as to what is lacking. Disposable equipment like ECG electrodes, IV equipment, pediatric sets, suction catheters, sterile gloves, nasogastric tube, oral airways, tracheal tubes, spinal needles and batteries. Sometimes the OTs do not have batteries also. So that is something which is difficult to digest. Another important aspect which is the legal aspect of safe practice of anesthesia, that every anesthesiologist must conform to the country's regulations, because wherever he or she is practicing, he or she must conform to the regulatory bodies, whatever their guidelines are. And what are they? Duty to give medical assistance, information to patients and consent, documentation of all anesthetics, documentation of unexpected events, following up unexpected incidents, problems or deaths, and shortcomings with equipment, staffing, etc., which are an obstacle to providing safe anesthetics, to be reported to relevant authorities. So you are welcome to report this to your